two, one. Let me click on record. All right. All right. Good morning, good afternoon, good evening. Based on where you are watching me from and time of day, I salute you all for making time to join us today. I'm excited because of our guest speaker. It's been a short notice, but of course, he's always available to help. So he accepted it. And without any reservation, quickly we arranged this. So I'm excited to bring to you a colleague, an emergency physician specialist. Listen carefully, with the Anglo Gold Health Foundation, where he heads the emergency and intensive care units. He had his medical education, of course, with me together in the University of Ghana Medical School and postgraduate medical education, also with the Ghana College of Physicians and Surgeons. He's fully certified by the American Heart Association to provide advanced cardiac life supports, and also certified by the American College of Surgeons to provide advanced trauma life support. Please join me, specially welcome a brother, a friend, Dr. John Banning, JC, to share with us on the topic sudden collapse. Doc, over to you.
Yes, sir. Thank you very much, Dr. Sedo here. Yes, Albert was a colleague. Albert has been a friend for a very long time. And I must apologize for the background noises you'll be hearing. I'm babysitting today, so I have no way of escaping that. So, yes, we want to talk about basic life supports. I have a few slides. I don't know if I can go ahead and share them, then we just get started.
Yeah, go ahead.
Okay.
Go ahead.
I've seen a lot of people I know. I've seen Sixtus. I know Sixtus from my days in the district. Let me see. Hey, I'm getting technologically challenged. Which one do I share? This one. Okay, let me see. I'll share my desktop and then. Yes, please, can you see my screen?
Yeah, I can see your desktop.
Okay, all right, then I'll just go ahead and start. Okay, so first of all, I want to say that the topic, sudden collapse, I'm going to talk about it I'll try as much as possible to make it friendly for somebody who is listening to me who doesn't have any medical background. So that is how I want to make it. And in fact, that's the reason why I chose the topic sudden collapse. So let me just go straight ahead. Now, to collapse simply means to fall to the ground, which is a non-mechanical fall. And this is termed medically as a syncopal attack or syncope. And syncope is sometimes interchanged with fainting. So you hear that somebody has fainted, is used interchangeably. But then along the way, I think I'll also point out that fainting actually is a type of syncopal attack or syncope. It forms a category when you are talking about syncope. Now, syncope is a brief loss of consciousness with a quick recovery, and it happens when there is a sudden temporary drop in the amount of oxygen that your brain is receiving. When a person collapses, the priority is to identify life-threatening problems, and then you want to institute first aid for such victims. So in the course of today's presentation, we will look at how you approach one very life-threatening occasion when a patient collapses or when a patient loses consciousness. Now, if a person collapses, you want to ask yourself if it's a simple faint. So there are three categories. Either it's a faint, or it was a seizure, or it has a cardiac cause. Usually these are the reasons why a patient or a person will lose consciousness briefly. Now, when we're talking about simple faints, it's usually a response to an overwarm environment or to prolonged standing. So if you can cast your minds back, you realize that during Independence Day parades, you have a lot of kids collapsing. They collapse whilst they are marching or whilst they are parading. And it's because of, it's a type of faint. It's a type of faint. Now, it's also not unusual for somebody to faint because they've had a sudden fright or they've had a strong visual stimulus. So somebody sees blood, for instance, and then they collapse. In fact, I remember when I was working in St. Martin's Hospital in Agresum, I was once performing a cesarean section on a client. Then there was a student nurse who came in to observe. As soon as I made my incision, made a cut, and then she saw the blood gush out, she suddenly collapsed. Then, we're all just asking ourselves, what is happening? What is happening? But I mean, it was just a fainting episode that she had. So she had a brief loss of consciousness, and then she had complete recovery, once she was lying flat, and then the stimulus was no more there. So visual stimulus can be a precipitant. It will interest you to know that binging on a large meal can also cause a person to suddenly collapse. Prolonged starvation, alcoholic binge, all these can cause a person to collapse. Now, with simple faints, usually the person has some symptoms before they collapse. They have these premonitory symptoms of feeling unwell, or some will be nauseated, some will feel dizzy, some will feel tired. Some will have tunnel vision, some will have altered hearing, some will have blurred vision. I myself have had a blurred vision because I was starved for a long time in the morning. And in fact, somebody was looking at me. I couldn't really recognize the person. So I had to rush, get something to eat. And then, feel all right. With this type of collapse, it's important to lie the person down. Now, the reason is that I already said when a person collapses because there is a transient reduction in blood flow or in oxygen flow to the brain. So imagine that you are standing upright. That upright posture means that there is also gravity acting to sort of keep some blood in the lower part of the body. Now, God in his own wisdom has said that, well, if there is that transient reduction in blood flow to the brain, then he will cause you to collapse, or he will cause you to fall down or lie flat. When you lie flat, the element of gravity is eliminated. And when that element of gravity is taken off, then blood can flow freely to the brain and then cause you to regain consciousness. So this is sort of an intelligent design or an intelligent mechanism to help the patient or to help the person that has suddenly collapsed. Now, the next thing or the next group is you ask yourself, so if it wasn't a faint, if it wasn't a simple faint, was it a seizure? Working in the emergency departments, I've come to realize that patients are brought in with a story that, oh, They were there, they were fine, then suddenly they collapsed. You probe, and you realize that actually the person had a seizure or the person had a convulsion. So these are the clues that will help us to know whether it was a seizure or not. The person may be known to have history of a seizure disorder. Sometimes they have identifiers on them. Some wear bracelets, some will put a chain around their neck or a tag around their neck to indicate that they have this sort of medical condition. And often with these people, they have a loud cry preceding the collapse. And of course, what you can't miss is the jerky movement of the limbs that they also have. Sometimes they may have this bluish discoloration of the lips or the tongue, or they may have this saliva frothing from the mouth. Oftentimes too, after the seizure, you see them breathing heavily, or in the course of the seizure, some will bite their tongue, so they will have blood in their mouth. Some also have what we call incontinence. Like at the time they will have the seizure, they will either wee-wee on themselves or they will poo on themselves. So that's a urinary or fecal incontinence. And this one is usually indicative of what's a generalized seizure. Now, after the seizure, they may be drowsy or have confusion. And usually the recovery is rapid. Now, the third category, which is also interesting, is you ask yourself whether it was a cardiac event. Cardiac events are usually abrupt in onset. The person is fine 1 minute, the next minute, they are falling to the ground or they are collapsing to the ground. They don't have those premonitory symptoms that I talked about for the simple fainting. And also, cardiac events may be associated with excessive sweating or palpitations. And sometimes the patients may actually have had a previous episode and they may come in with chest pains or palpitations. Palpitations is simply an awareness of your own heartbeats. As you are sitting down now, your heart is beating, but you are not aware of it. Okay. Now, when you become aware that my heart is beating fast or my heart is beating slower, then we say that you are having palpitations. Some of these patients who will have history of cardiac disease, or they may have family history of sudden death. Okay, they have an uncle, they have a senior brother, or their parents, one of their parents was well. Then suddenly they got sick, they were rushed to the hospital, then they died. Okay, so that is usually how sudden cardiac death occurs. Now, I want us all to note this very important point. If somebody collapses whilst they are doing physical activity or they are exerting themselves physically, okay, then it's a worrying feature. Syncopal attacks or sudden collapsing, which occurs with physical exertion, the possible causes will include aortic or mitral stenosis. Now, the valves in the heart, these are valves in the heart. Sometimes they become scarred and then they become narrower than their normal diameter. When this happens, then we say the person has stenosis of the heart valve. Depending on where it is, it's either the aortic or the mitral valve that usually causes these problems. Pulmonary hypertension. So this one too, when the pulmonary artery, okay, in a person, the pressure inside is elevated beyond the normal, then we say the person has pulmonary hypertension. There are some conditions that can cause a pulmonary hypertension. Usually, a person with lung problems or what we call a pulmonary embolism, they can develop pulmonary hypertension, sorry. Cardiomyopathy. Because I know a lot of people listening to me today are young people, I put in cardiomyopathy. Now, this is one condition where you won't be aware that you have unless something has happened or you have gone for screening and then they have detected that you probably have this particular condition. somebody develops cardiomyopathy when the heart muscle itself becomes diseased, and usually they become bigger, and they tend to obstruct the outflow of blood. So we have a condition called hypertrophic obstructive cardiomyopathy. That is when the heart muscles become big to the extent that they even block the outflow of blood. This one happens a lot of the time in the young people who were well, then one day we hear that they collapsed and then they died. Most of the time, these are the causes, okay? A person with coronary artery disease, this one happens in much older people or people who have diabetes or hypertension. They are the ones who develop coronary artery disease. The vessels that supply the heart pumps out blood, but there are vessels that supply the heart too. When these vessels, their inside becomes narrower than normal, then the amount of blood that is supplied to the heart is reduced. So such people, if they exert themselves, they can develop what we call a heart attack. That's reduced blood supply to the heart itself. I was talking about the young people and hypertrophic cardiomyopathy. So if you look at this image that I'm showing on the screen, on the left of the screen, there is a normal heart. This is how a normal heart looks like. The muscles are not so big, but then if you look at this one on the right side, you realize that the heart muscles are so big. So they become so big that they sort of obstruct the outflow of blood. And this is actually a condition that is quite worrying. Okay, it's quite worrying. Some people they tend to develop this not because they have done anything, but they were born with a certain predisposition to develop this condition. All right, so that is how come this particular condition also happens. There are other causes. So you can have carotid sinus. The young men who go and then have a shave, okay, they are shaving close to where your carotid sinus is, okay, around the angle of the jaw and the neck, all right. There, they can stimulate the carotid sinus and then cause your heart rate to unusually slow down and cause you to have a collapse. This is very rare. Some people too, just by turning their head, especially if they turn it suddenly, sometimes they can collapse because of that. But these are usually rare and then they tend to resolve quickly as well. People may also collapse because of the effect of medications. So glycerol trinitrate, beta blockers, some medications used to treat high blood pressure as well can cause patients to or people to collapse to the ground or collapse to the floor or have a syncopal attack. Now, I've highlighted a few of the causes in red. Now, these are life-threatening causes. They are causes that, for the health workers amongst us, I would say that they are causes that we should not miss. Because if you miss these causes, your patient is going to die on you. Some of them, in fact, most of them that I've highlighted there, they are things that we can do something about. We call something ruptured ectopic pregnancy. So in the young women, those within the reproductive age group, you may take seed or you may become pregnant. And the pregnancy is so, the fertilization usually happens outside the uterus, happens within the fallopian tubes. And usually it will come and then lie within the lining of the uterus. Sometimes this doesn't happen. After the fertilization, it doesn't migrate into the inside of the uterus, okay, or the endometrium. Then along the way, it starts growing. If it happens to be in the tube or anywhere else outside the uterus, it can enlarge as the pregnancy is growing and then cause some blood vessels to sort of burst, if I should put it that way. And when that happens, we say the person has a ruptured ectopic. The young woman may be losing so much blood into the abdomen. And if care is not taken and then it's not detected early and something done about it, then the person may lose their life. Aortic or carotid dissection. Okay, this is also when the aorta or the carotid, these are big blood vessels within the body. Okay, now usually people with hypertension can develop this sort of thing. Okay, where these big vessels, there's a tear inside. And if there's a tear inside a big vessel like that, then the person loses blood into it continuously. It also happens in people who have what we call aortic aneurysm or carotid aneurysm, where there is a dilatation at a point, a part of the vessel enlarges, it abnormally enlarges, and the wall becomes thin. So when that happens, then there can be a tear in that big vessel and the person may lose all their blood. It's quite difficult to pick it up and it's very difficult to also treat it. But thankfully, it is very rare. Pulmonary embolism. This is when there is a clot in one of your veins, your deep veins, I should put it, not your superficial veins, your deep veins. Like there are deep veins in your calf, deep veins in your thigh, okay? And then it goes all the way into your lower abdomen and then comes to the heart. So those vessels, you can develop a clot in it, and that clot can migrate all the way and go into your pulmonary artery. If it goes to lodge in the pulmonary artery, then we say you have a pulmonary embolism. This can be quite deadly, okay? So somebody, let's say, has taken a long flight or a long journey from Accra to, let's say, Tamale, and you sat down quietly. Clots can form in your legs, the veins in your legs, and with time, it can migrate and go into your lungs and cause pulmonary embolism. So if you are traveling, make sure you have enough leg room, so that you can move your legs about so blood can move freely within your lower limb veins. Gastrointestinal bleed. So sometimes patients can bleed into their tummy. They can bleed into their guts or their intestines. And this is gastrointestinal bleed. Okay. All right. Now, what should you do? Somebody has collapsed. What should you do? Okay. I wanted to simplify this so much so that I looked at various algorithms out there and decided that this is what I'll talk about. So there is an acronym there, Doctors ABCD, okay? Or some will say Doctors CAP 2, CAB, Doctors CAP. But then I felt that for a lay person, this would be quite simple for you to follow. The first one, which is the D, is to look for danger. So look for dangers to yourself, to the person who has collapsed, and then to any other people who are coming to help you. And then check for response. So ask their name and squeeze their shoulders, both shoulders. So you shout the person's name. Albert, Albert, are you okay? You are looking for response. Then you send for help. 000 is an Australian emergency number. Ghana, our emergency number is 112. I understand there are challenges sometimes with getting emergency services through 112. So within the lecture, I'll project emergency number for wherever you are in Ghana. The National Ambulance Service, they have a control room, and you call these numbers, you can be helped, with your emergency. Send for help, that's the next. So DRS, Doctors ABCD. So send for help. So call that people should come and help you. Tell them to call the emergency line and then ask for support. If you are in the office, you are calling for the ambulance to come to the office and pick the victim to the hospital. Sometimes we actually think that just rushing the person to the hospital is the answer. But I want to tell you here today that no, sometimes that is not the best course of action. Sometimes there are little things you can do to buy yourself time. And that is why we are having this chat, or we are having this presentation today. So check the airway, open the mouth, look for foreign material. If there is any, take it out if you can. If you can't see, don't go poking into the person's mouth, when you can't see anything obvious to take out. Now check for breathing. So usually you check for breathing, and then you check for the pulse as well. With the pulse, if you slip your 2 fingers from your neck going towards the corner of your jaw, okay, you feel a pulsation there. That is your carotid pulse. All right. Now let's say you've checked and then you felt that the person is not breathing. You shouldn't do it for more than 10 seconds. Within 10 seconds, you should take a decision that the person is not breathing or the person doesn't have a pulse. Then you are supposed to start your CPR. I'll go through the CPR briefly in the course of the presentation. And then one important thing I will talk about today, use defibrillator, okay? The AED, automated external defibrillator. This is able to guide any person through CPR or through resuscitation, even if you have no prior knowledge of how to perform CPR. It gives you voice prompts to do this one. And I'm hoping that we can all be advocates in our workplaces for us to have AED, whether in the hospital, in the bank, or in the schools, or in the gym, or the station. Okay. In fact, it's postulated that one big man who passed away in Ghana, probably if there was an AED in wherever gym that he went to, maybe they could have done a proper resuscitation there with the right knowledge and then the right skills. Now, let's say you check the response, the person was unresponsive, but then you checked, they were breathing normally, okay, and then they had a pulse. Then what you can do to help the person is you are going to put them in the recovery position. Or let's say somebody has had a seizure, you observe them having a seizure. Now they have finished convulsing, now they are unconscious, okay? They are lying there unresponsive. What you can do to help them is to place them in the recovery position. So in the upper left corner, that's the first step. You hold one hand up, okay, as the lady is doing in this corner. And then number 2, you put the other hand to the side of the opposite cheek, as she has done here. Then you come to number 3 here. You lift the leg that is farthest away from you till the foot is flat on the ground. So she has bent the knee here and the foot is lying on the ground. Then the last step that you do, so you don't have to be a macho man to do this. If you perform the technique correctly, I assure you that even if the person is bigger than you, twice your size, you can just roll them onto their side with this technique. So the last one is with the knee that she has flexed, okay? She's going to use that knee to turn the person onto their side so that now they are sleeping on their hand, okay? So the hand is what it's supporting the head and the mouth. The mouth is towards the ground. This is important so that when they have secretions, they will not, the secretions will not go back into their airway and block the airway. If they have secretions or blood in their mouth, you want it to come out. So that is how you do it. And the head is tilted so that the airway will be open. The knee is what stops the body from rolling onto the stomach. Okay. Okay. So I'll leave this with Albert. These are the various regions and then their emergency numbers, national ambulance, the control room numbers. Okay. I've spoken to one of the regional managers of the national ambulance, and he assured me that usually if a person has to be transported from residential areas or from offices or wherever, if you call their helplines, and then they support you, and then they come and pick the patient. Usually, you will not face the challenge of paying for full support and all those things, okay? So I myself, I'm a beneficiary of the National Ambulance Service. 2 years ago, I called them, had a medical emergency in the house. I called them, they came to pick the person professionally and then send the person to the hospital. It was even later on when we have gotten to the hospital that they realized that, oh, it's me. And I used to come and teach them at their training school. Okay. I used to teach them, at their training school there. So. But these are their numbers. Now, let's say the person you checked on, the person who has fallen unconscious, you checked, they were not breathing. You felt their pulse, they didn't have a pulse. Then we say they are in cardiac arrest. So a person suffers cardiac arrest when the heart suddenly and unexpectedly stops performing its function of pumping blood. Now, most out of hospital cardiac arrest, most of the cardiac arrest that occurs outside the setting of a hospital is usually because a person has an abnormal heart rhythm. Okay. And that is the reason why I'll talk about the AED as we go along. Now, if let's say you have checked, the scene is safe. You have checked, the person is unresponsive. Then you have to now so you verify that the scene is safe. Then you check for responsiveness, as we talked about. So you shout for help, and then you activate the emergency response system. If your office happens to have an AED, then you call for the AED. Okay. Now you check whether the person is breathing or not, as I indicated earlier, and then whether they have a pulse. If they don't have a pulse, then we say they are in cardiac arrest. So what you want to do is to start chest compression. Okay. You are going to start chest compression. If that's the only thing if that's the only thing you can do, it's actually better than doing nothing. For the person who has stopped breathing, who doesn't have a pulse, if the only thing you can do is chest compression, it is better than doing nothing. However, if you can do your chest compression and then also help the person breathe, okay? Now, outside the hospital setting, what you can do to help the person breathe is what we call mouth-to-mouth ventilation. So with that one, I think there is a short video ahead which demonstrates this. So maybe when we get there, then you learn how it is done. But then basically you pinch the person's nose, you cover the person's mouth with your own mouth, and then blow air into them. That is how you help them to breathe. So you do that. And then when the AED comes, you switch on the AED and then listen to the voice prompts that the AED will give you. Sorry.
If the scene is safe, approach the victim and assess their responsiveness. Send another person to activate the emergency response system and get an AED if possible. Assess breathing and check carotid pulse. If the victim is not breathing or only gasping and has no pulse, begin CPR starting with compressions. Perform 30 compressions at a rate of 100 to 120 compressions per minute at a depth of at least 1/3 the chest. For adults, this is at least 2 inches. Open the airway and deliver 2 breaths, each lasting 1 second, and watch for chest rise. Resume compressions. It is important to minimize interruptions in chest compressions to 10 seconds. When the AED is brought to scene, begin by turning the device on. Remove any clothing from the victim and apply the AED pads. Plug in the connector and clear the victim while the AED analyzes the rhythm. If no shock is advised, Resume CPR beginning with chest compressions. If a shock is advised, clear the victim again before delivering the shock. Once the AED has charged, hit the shock button. After delivering the shock, resume CPR beginning with 30 chest compressions. Open the airway and deliver 2 breaths. Continue at this ratio of 30 compressions to 2 breaths until the AED prompts you to stop or further help arrives.
Okay. All right. So that was a quick one. But I believe the video will be available later. You can go through it as many times as you want. Now, what is the AED and why the need? In fact, one of the advocacies I've started doing is to advocate for facilities, healthcare facilities where they don't have people skilled enough to read abnormal heart rhythms and all that, for these facilities to consider buying the automated external defibrillator. In fact, not just health facilities, but then I'm advocating for offices to also acquire these devices to help manage emergencies. Now, earlier this year, I was informed of the sudden death of a friend or a colleague who had gone to school. In my view, I think that she had cardiac arrest, possibly from an abnormal heart rhythm. I'm saying that because within the last 6 months, I've seen 2 young women. They didn't have any cardiac condition. They didn't have any medical condition at all. They went to their normal job. One was a teacher, one was a trader. They went for their normal job. Then whilst there, they began feeling funny. They had palpitations. They had an awareness of their own heart beating. Then one of them collapsed to the ground. So she was brought to our emergency unit here at Anglo Gold Ashanti. When we analyzed her, we realized that she had an abnormal heart rhythm. So we had to get a defibrillator, put it on her chest, and shock her back to normal heart rhythm. She survived. The second patient, who was a trader, also abnormal heart rhythm. Both of them survived. Okay. Now, the AED is a computerized device that's able to analyze the heart rhythm and appropriately deliver an electric shock to correct abnormal heart rhythms when necessary. And sometimes, in addition to your chest compression, in addition to your ventilation, then you improve the patient's chances of survival. I believe I have an image of it somewhere. Okay. So in advanced countries, the AEDs are placed in sports stadia, airports, train stations, and other public places. Remember in the Euros, Christian Eriksen collapsed and he had to be resuscitated. I understand he had to be shocked twice before they got him back and then later sent him to the hospital. Now we have to realize there is an increasing burden of cardiovascular diseases in Ghana. Okay, even among young people, there is the increasing incidence of what? Cardiovascular diseases. Okay, and we have to prioritize the health of the public and make these devices more available. So this is how the AED machine looks like. I mean, this is one brand, but then there are several brands. And depending on the manufacturer, they look a bit different, but their operations are basically the same. Okay, I'm not going to talk about how to use the AED because it will be a long lecture, but then I think the most important thing is if an AED is available, the only thing you need to do is to switch it on. As soon as you switch it on, you hear voice prompts and it will tell you every single thing that you need to do and also help you with your resuscitation, as in how many times you need to push the chest, how many times you need to ventilate. Okay, so it's a very important tool that helps in resuscitation. Now, to end my lecture, these are recommendations I'm making for individuals and for institutions. You should take responsibility for your own health. And then also share medical information with a trusted colleague. If you have epilepsy, tell a colleague, a trusted colleague, that I have a seizure disorder. If you have a heart condition, tell a trusted colleague, so that when the emergency happens and you are not able to help yourself, we will have adequate information to help you. We should do routine medical checkup with reliable health facilities, seek correct medical information from reputable sources as well, like we are doing today. And then for institutions, I'm recommending that they should have first aid posts or first aid kits at offices, and everybody should know where this first aid kit or first aid post is located. Institutions should also plan and have basic life support training for staff regularly. And I should have made this one in bold. Acquire AED and then train your staff. And also prioritize your pre-employment and periodic medical checkup for staff. These are very important, so that if somebody has an underlying problem, you are aware of it, and then we can help the person before the emergency arrives. Everyone is only one step away from a medical emergency. As I'm giving this lecture, I mean, nobody knows what happens next. So all of us, we are all one step away from a medical emergency, okay? I may slip, injure my knee, I may fall. I mean, anything could happen to any of us at any point in time. So we should always keep that at the back of our mind. Knowledge in basic life support and having an AED on hand can make all the difference in such situations when you have medical emergencies. AEDs are simple to use, and any layperson can be trained on how to use it as well. So, Albert, I'll pause here and wait. If anybody has any questions, then we'll take the questions. Thank you.
JC, for such an elaborate presentation, teaching us and educating us on what to do in case of this, in case of that. Now, the floor is open. Please put your questions in the chat box in the comment section. Dr. John will, I call him Johnny. That's why it's getting difficult for me to call him JC. I call him Johnny. All right, so he will help us answer all the questions. For please take advantage. He's here. You hardly get some of these people just, like that. He's quite busy. That's why I'm impressed that he took upon this task and decided to honor this invitation. Please ask him all the questions, any form of emergency, even outside of what he has taught us. Emergencies, that's where his field is. He is the head of the emergency unit and intensive care unit at Ashanti Gold. You know that. So, opportunity has come. Take advantage. Put your questions in the chat box, in the comment section, and Dr. John JC will gladly help us to answer all of them. So, John, first of all, I will kick off with my question. So, somebody will ask, definitely along the line, that when somebody, you think somebody has a heart attack, a cardiac arrest, what should be the number of chest compressions to the ventilation, the mouth-to-mouth breathing? What should be is it 50 to 1, 30 to 2? What is it?
Okay, Albert, thank you. So, in the video and then as well in my slides, I stated that when you are doing the chest compressions, if it's an adult, then you do 30 chest compressions and then you give 2 breaths. 30 chest compressions, 2 breaths. 30 chest compressions, 2 breaths. Then after 2 minutes, you have to check whether the person now is breathing and has a pulse or not. You do that for not more than 10 seconds. Then you resume again. 30 chest compressions, 2 breaths. 30 chest compressions, 2 breaths. So it's 30:2 in adults. In children, if you're alone, okay, then you are supposed to do 30 chest compressions, 2 breaths. But then if you are 2 or more and it's a child, then you do 15 chest compressions, 2 breaths. 15 chest compressions, 2 breaths. Okay. In newborns is different. So I won't talk about the newborns. I think the best person to talk about that would be a pediatrician. But then it's 30 is 2 in adults. And if you are 2 or more in children, it's 15 is to 2.
All right. Thank you very much. I will ask another question. Okay, there's a question, Doc. Where in Ghana can individuals get the AEDs to buy? Do you have an idea of the price as well?
For the price, I actually have no idea. But I think when we're looking for some to buy, I contacted some companies. I remember there's this company called Code Red. They are able to help even with the training of your staff on basic life support, advanced life support. They are able to do that training, and then they also help you acquire the AEDs. And then also, I remember HCE Medical Equipment. I think I dealt with them once, and they indicated to me they had the AEDs. So that is what I remember about that. But for the price, I don't remember. I don't remember for the price.
All right. Thank you very much. Again, the floor is open. Put your questions in the chat box in the comment section. Dr. John Jesse will gladly answer all your questions. We have a few more minutes to go. It's an opportunity to ask about any emergency. You see, that's his field. So he's comfortable asking any question with any emergency. So I'm taking advantage to ask more questions. Doc, what's the difference between drowning and near drowning?
Okay. All right. So I think, in fact, now there is no distinction between them, in the sense that at first we used to refer to near drowning when the person has fallen inside water, was submerged, and then survives. Then we say that was a near drowning incident. And then we used to reserve drowning for when the person has gone inside the water and then died as a result. Then we call that one drowning. But I think current nomenclature combines the two. So whether you die or you survive, we say that the person has drowned. Okay. So that's the current nomenclature.
If someone is able to help somebody out of the water who was drowning, is the resuscitation the same as what you've taught us?
Yes, please. The resuscitation is the same. But remember that you always have to do it safely. So safety is paramount. If the person was drowning, you have to take them out of the water, put them in a dry place. If you are going to use your AED, make sure the person is dry, because it's going to use electricity. So you have to make sure the person is dry. The area that you, the rescuer, you are standing is dry. Okay. But if you pull them out of the water, they are not breathing, then the process of resuscitation is the same. You have to start your chest compressions, and your chest compressions actually sometimes forces the water to come out of the airway. Okay. But under those circumstances, usually priority is to start the chest compressions. Sorry.
All right. Thank you very much. Somebody is asking, a friend's daughter chokes during sleep. What can she do to help her stop it?
Okay, so a friend's daughter choked during sleep. All right. So I'm guessing that the daughter, when she sleeps, feels like she's choking. So it may be that the child has a condition that we call obstructive sleep apnea. Okay. Or in children, sometimes when they have their tonsils are enlarged, sometimes it affects their breathing, especially when they are sleeping. They feel like they can't breathe. And for that one, usually they would have to see an ENT specialist. An ENT specialist will be able to do a thorough assessment and determine the cause of that particular problem. If it's because they are having an enlarged tonsil, then usually they do surgery for these people to relieve them of that obstruction.
All right, thank you very much.
Okay, thank you.
Somebody is asking, I sometimes, again, every one of you, please put it in the chat box, your questions, in the comment section, your questions. I'll read it out. Dr. John JC will gladly answer all the questions. Please take advantage, ask questions pertaining to any form of emergency. Let's maximize his presence here. All right, it's not all the time that you're going to have such people. We're honored to have him. Somebody says, I sometimes experience fast pulse for about 5 seconds around my throat and at times close to the heart. What should I do?
Wait, can you give me your question again?
The person says she sometimes experiences fast pulse for about 5 seconds around her throat and sometimes close to her heart. What should she do?
She feels what close to her heart?
Fast pulse.
Oh, fast pulse.
Yeah, fast pulse.
Okay,
yes.
Okay. All right. In that case, I think that she needs to do an ECG first of all. In fact, she needs to have a thorough assessment, okay, to determine why she's having the fast pulse. Okay, both clinically and then also by investigation. So by clinically, I mean that a doctor should assess her. Sometimes just by assessing her and listening to her story, you'll be able to determine the cause. Because some of the things that can cause somebody to have a fast pulse, one of them could be because he has thyrotoxicosis, or her thyroid hormones are too much. Okay, that could be the reason why she's having that. Or it could be from the heart itself. All right. But sometimes just listening to the patient, it directs you on what investigations you need to do. Okay. Sometimes you have people coming to you as a doctor and then saying that, oh, Mami Nkoye test way, or let me go and do this test. Okay. Sometimes you have to listen to the story first, and then based on the story and then the examination, it usually points us in which direction to look for the cause of the problem. So I would think that the person would need to see a doctor, and then at the minimum should have an ECG done, an electrocardiogram. When that electrocardiogram is done, it's able to tell whether there is an abnormal heart rate or it's normal, or whether there is a rhythm problem or not. That ECG is able to help determine that. Okay, thank you.
Thank you very much. Yes, one of the essence of this education is to acquire knowledge, and when you acquire knowledge, you use it. So if through the education you realize that you could be having something, we always advise you go to the hospital, get thoroughly checked, do all the necessary labs, and the doctors will advise you. The aim of this weekly program is to help people not fall in the hands of, spiritualists, herbalists, people who don't know what they are talking about. So you know that this could be this and that. So we may not be able to prescribe medications for you here, but we advise you seek expert medical knowledge, expert medical services at the hospitals where you can be treated. All right, thank you very much. Somebody's asking, Doc, is it advisable to put a spoon in one's mouth when he or she is convulsing?
No, a big no, please. You should avoid that temptation to put a spoon in their mouth. Apart from causing trauma, you don't know whether that can also even contribute to occluding or blocking the airway. So I'll say that that's a big no. One of the questions I was expecting was, if somebody collapses suddenly, should we pour water on the person? Because I think It's one of the commonest things we do in Ghana. Somebody collapses,
Yeah.
water is life. Let's pour water on the person. Okay. So it is not the right thing to do. Okay, it is not the right thing to do. The right thing to do is what we have tried to go through today. Pouring water on a person, that's not the reason why the person will regain consciousness. Remember, when I was explaining, I said that sometimes by the person collapsing and lying on the floor, with the element of gravity gone, the person may regain consciousness by that. Okay, so usually what happens is the person has collapsed. Let's go and bring water. By the time they come back, the person is lying on the floor, enough blood has gone to the brain, then the person regains consciousness around the time they are putting water on the person. The only situation I see maybe that's having a benefit would be somebody who has collapsed because of an overwarm environment from heat exhaustion. Okay, but even that, you have to be careful that the water you are pouring on the person is not going into the airway. As the person is lying down, water can go into the nostril, water can go into the mouth, can go into the airway and block the airway. So you have to be cautious and conscious about that harmful effects. All right, thank you.
All right. Again, for those of us who joined us late, a lot of knowledge was shared, and if you are willing to benefit from it, you can just click on the link in the chat box on Zoom and subscribe to the channel. I'll be sharing the recording shortly after this so that you can get to watch the full video. And of course, you have the benefit of also benefiting from the previously recorded ones as well. Dr. John, I want to ask a question. What are some of the home remedies if somebody suffers a burn?
Okay. So if somebody suffers a burn, the first thing you want to do is to, if there is active burns, then you have to try and put out the fire. Okay. And then also you want to put water on it, not very cold water. Okay, because a person may go into hypothermia. Okay, so just normal room temperature water, clean enough, then you want to put it on the burns. And if it's not a huge burn or it's not a large burn, then after cleaning the area with water, you can apply some Vaseline on it so that the person doesn't sort of lose water through that part of the skin. All right. And you should avoid putting these local remedies on it. I have one picture with me. It's so terrible. Person suffered burns and they put some concoction on it. Later on, this person got sick not because of the burn they had, but because of the local remedy that they applied on it. Okay, so I think that just having Vaseline, if you happen to have what we call silver sulfadiazine cream, then that will be the best for those minor burns that yourself or your child will suffer. But if it's a large burn, okay, if per your estimation is bigger than, let's say, your palm, okay, then I will advise that you go and then have it assessed as soon as possible. In fact, you should have all those burns assessed at the earliest time that you can. All right. But then generally burns that will be bigger than your palm, or they happen close to a joint, or burns on your face especially, or if the burn happened with an explosion, okay, then you should, as soon as possible, be assessed in a hospital. Or let's say the burns happened in an enclosed environment because of the risk of what we call inhalational injury. Injury because as a result of the burns affecting your airway, okay, that's inhalational injury. Then you have to be assessed in a hospital as soon as possible. So all those gas cylinder burns, you can't keep them in the house. Electrical burns, if you sustain the burns because of electricity, no matter how small that burn looks like, as soon as possible, you should go to the hospital, because electrical burns can result in abnormal heart rhythm. The person can actually go into cardiac arrest because of what you think is a small electrical burn. And sometimes it's small on the outside, but inside it would have caused a lot of damage. Okay, so I think those are the basic things you can do in the house if you have burns. Get a place suited with some water, and then you can apply Vaseline on it and get it checked out as soon as possible.
All right, thank you. Now, back to the question the person asked about putting spoon in the mouth when somebody is convulsing, which is a no-no. What should the person do to avoid the victim biting his or her tongue?
Okay, with a tongue bite, sometimes it's inevitable. Even in a hospital, sometimes the patients will bite their tongue. That itself is not problematic. It's not so problematic. Let me choose my words carefully. It's not so problematically if the patient has had a convulsion and has a tongue bite, okay, as opposed to the danger of you causing an airway obstruction, okay, that one is unacceptable. So I think that usually you want to weigh the benefits against the risk. And sometimes you try, if they are having a convulsion, that's not the time for you to try and say that you are preventing them from biting their tongue. So you are going to hold your mouth together apart, for instance. Okay, you have to try and then avoid that. So it's always about the risk versus the benefits. Okay. Sometimes it's inevitable that they'll bite their tongue, and it's something that can be treated in the hospital. Okay.
All right. The common knowledge in the past used to be in a hospital setting, especially putting a padded spatula. Is it still the same?
Putting a padded spatula is not routine. It's also not routinely done in an emergency setting. If you are within the hospital setting, then your focus is on aborting the seizure and then also preventing further seizures and maintaining the airway. Okay, so somebody will, for instance, has had a seizure, or and then they happen to have aborted the seizure. They can put an oropharyngeal airway or a nasopharyngeal airway, clear the airway of secretions or blood, and then focus on giving drugs that will prevent the next seizure. So even in a hospital, you realize that the priority has changed. Why do you want the person to have the convulsion and then now prevent them from biting their tongue? The focus is more on what's preventing the next seizure if the person has managed to come to the hospital, for instance.
Yes, thank you very much. Okay, again, this I remember this in medical school days, where we were told somebody was giving a speech, and it was obvious that the person was looking like he was about to fall, and it was a very high-profile person, and people around him thought they were helping him by not allowing him to fall. They were trying to hold him up. It took one of our professors back then to quickly intervene, allow the person down flat, and then loosen his tie around the neck. And that was life-saving. So that is why this training, for example, here, Dr. John Jesse, he said it several times, let the person lie flat, gravity is out of the way, blood flow returns to your brain, and you allow it to recover spontaneously, and other things. So these things can be very life-saving. Imagine at a graduation ceremony, the VC is giving a speech, he has some exhaustion, he wants to maybe fall to restore things to normal, and people are holding him up so he continued the speech. You know what can happen. So thank you very much, Dr. John Jesse. Anybody else has any question? I'm just taking advantage and asking all emergency questions. I don't know about you. So if anybody has any question, please put in the chat box in the comment section so he can help us. We have 1 more minute to go. If anybody has any questions, put in the chat. Okay, what then should you do? Okay, yeah. So, Mary Pius, the answers have been given. What then should you do when somebody starts convulsing? Okay, let me give it to Dr. JC. What should somebody do at home when somebody is convulsing?
Okay, so at home, if somebody is convulsing, try and roll the person to their side. Since you will not have the drugs that will help the convulsion cease, let them just lie on their side and prevent them from injuring themselves. Okay, so the convulsion will happen on the floor. There is nobody who has convulsed while standing or sitting up. Okay, they will usually convulse on the floor, or they will fall to the floor and then have the convulsion. So make sure that the person is on the floor, roll to their side. You can put an arm on them, okay, so that they remain on their side whilst they are convulsing. Usually the convulsion will not last long. When that convulsion ends, then as soon as possible, you want to transfer the person to the hospital. Okay.
All right. Thank you very
much. When I was a resident in Komfo Anokye, I wanted to just say that when I was a resident in Komfo Anokye, there was this sad case where somebody had a convulsion, and I don't know what happened, but she happened to have fallen in hot oil. Okay. Instead of the people there trying to help her, keep her safe, they were all afraid with wild stories that, oh, if the person is convulsing and then the saliva touches you, you're also going to start convulsing. So they all ran away, and then this girl now fell into hot oil and then sustained burns from that. Okay. So the convulsion will not affect you that way. So you try, roll them to the side, keep them safe. When the convulsion finishes, send them to the hospital. Thank you.
Yes, thank you very much. 30 seconds more. Anybody has any question to ask, feel free, put in the chat box. Dr. John G will help us with them. We've learned a lot. Again, if you joined us late, you missed a lot. The link to the channel is in the chat box on WhatsApp, on Zoom, sorry. Click on it, subscribe, put a notification on, and when we are done, I'll upload the recorded version there, and you get to benefit as well. Now, there's a last question from Charlotte. Says, if ECG proves normal, should a person with rapid pulse once a while take it? I'm not getting the question though.
I'm not getting the question well.
Yeah, I'm not getting it, but I'm just reading as it is there. Saying if ECG proves normal, should a person with rapid pulse once a while take it normal?
If the ECG is normal, then I believe, on that side, yes, the heart rhythm and all that is normal. But then if the person still feels they have palpitations, they feel their heart beating faster, then of course the ECG is not the only means of investigating them. So there are other modalities for sometimes you even do what we call stress testing, where we do ECG or other testing whilst the person is under stress, okay, like they are on a treadmill or something, then we do it to see whether we'll find any abnormality. Sometimes we do ultrasound, okay. Sometimes they do some radionuclide investigation as well under those stressful conditions to determine heart rhythm. So the ECG is not by any means the only way to assess whether somebody has an abnormal heart rhythm, but is the basic minimum for somebody who has been having palpitations or feel they have an abnormality with the way their heart is beating. Is the basic minimum.
And just as an addition, you can have someone who feels their heart is beating very fast, and there could be other causes. General anxiety disorder is one of them. There could be other things. So after investigating to be sure there is no physical problem with the heart or with the rhythm or whatever, there could be other causes as well. Again, if there's a need for you to be referred to see another specialist, you will be. So that's what I will have to add to it. Yeah, so Mami Pokia says exactly what she was about to ask, that convulsion or social disorders is not contagious. So if somebody is convulsing, you can help the person keep safe. Touching the person's fluid or saliva or whatever will not make you have the condition. It's very important for us to make that clear. Dr. John GC made it clear. The person's saliva touching you, body fluid touching you, you touching the person will not make you have the seizure disorder. Let's get that clear. It is something that is a lie, and it keeps being passed from old people to the young generations, and it keeps going on and on like that. It's not true. It's not true. It's not true. Somebody says, I am at home and I see my dad having some abnormal or slurred speech and unable to move as normal. What could be happening and what should I do?
Okay, so slurred speech, abnormal movements. I don't want to what should I say, jump the gun, or but I think one of the things that could be the cause would be a stroke. And with stroke, time is of essence. So as soon as possible, I want him or her to get the dad to the hospital to be assessed as soon as possible. You will likely do a brain scan and see whether there is a stroke or not. So that's I think that the person needs to get the dad to the hospital.
Yes, it's an emergency. Stroke is top on the list. It could be other things as well. We don't know yet. So now you know that when such things is happening, it's not spiritual, it's not caused by curses or anything. It's something very, very medical. Quickly get your dad the needed medical attention as soon as possible. Thank you very much. Our time is up for today. Unless somebody has an emergency question to put in where an emergency physician specialist will handle it for us. So we all appreciate Dr. John Banin JC for his time spent with us today. We learned a lot. And for those of us who joined us late, the recording will be posted on the YouTube channel. Feel free, go watch and share with your friends as well. Please, together join me, say a big thank you to Dr. John Banin JC. Please, Doc, can you pronounce your full name for us? The B-A-N-I-N. I want to get the traditional pronunciation.
So it's spelled B-A, but it's pronounced Benin. So John Jesse
it's John
Benin.
John Benin.
Yes, sir. John Jesse Benin.
Pardon me for slaughtering your name. It's John Benin. Yes, John Benin. I always call it John. You know, that feeling where you can be in a class with somebody and you don't know the person's full name, right? You just have a nickname you call the person by. Yeah, so it's John Benin. JC, thank you very much for time. Please join me in the chat box. Appreciate Dr. John Benin JC for his time. Quite a busy man. You heard him. He is even babysitting. His kids are in the background, but he decided to devote to educate us on this very important topic. All right, so please, in the chat box, let's show him some love in the chat box. Let's all say thank you, Dr. John Benin JC. Let's all show him some love in the chat box on Zoom where he can see it for himself. Thank you very much, Doc. We appreciate your input, and I know when we call upon you again, you will honor our invitation. Thank you very much, everybody. Let's all show love to Dr. John in the chat box. Let's say thank you, Dr. John Benin JC, in the chat box. Let's all appreciate his efforts. We appreciate you so much. Thank you, thank you, thank you, thank you. All right, so on that note, once again, I must say it's been a pleasing pleasure once again serving you all. Until next time, this is Dr. Albert Sedo here. Catch you soon.